for every height,
Yeah.
there should be a weight. Or every weight should be an assigned height. So if your weight compared to your height is too much, then we say that your BMI is high.
Right.
So in terms of mathematical sense, what you do is that you check your weight in kilograms.
Right.
And then you check your height in meters. Then you square your height. Those that are still weak in math, you multiply the height by itself.
Right.
So if your height is 1.5 meters, you multiply 1.5 meters by 1.5 meters.
Yeah.
That is a squaring the 1.5 meters. And then you use that figure to divide your weight. So for example, if my weight is 80 and my height is 2 meters, then I'll multiply 2 by 2. 2 by 2 is 4. Then I'll use the 4 to divide the 80. That is 20 in the end. So my BMI is 20.
Right.
So that's how you do the mathematics.
Okay. It's to you it's very simple, but to me I'm a bit lost. But I'm sure the audience go it.
It was too much.
I did not get it, but maybe.
Oh, this one I've broken it down like that.
That's a lot. That's a lot of information right now.
Oh,
but maybe I'll watch the video again. Because even if you repeat it right now, I'm not sure.
Let me repeat it
Okay,
again.
all right.
So,
We are working so hard to bring you the voices that matter and to tell the most inspiring stories. Please subscribe to our YouTube channel to become part of our growing community.
Hi, ladies and gentlemen. Spare us a bit of your time. Let's educate ourselves today. I present to you Mr. Rosie. Is it Rosie? Rosie. We're going to talk about breast cancer today. It's very important to all of us, even if you are male, it doesn't matter. Let's listen and educate, and so we can help ourselves and help other people as well. Okay? So, Mister, I'm sure people will be wondering, why is a uniform man coming to educate us about breast cancer?
I mean, it's in the military, we have different professions.
Okay.
It's like a country on its own. So we have engineers, we have teachers, and we have lawyers, and we have doctors, nurses, and whatnot. So I happen to be a doctor.
Okay.
Yes,
In the military. All right. So then, can you still, stay on that line and tell us a little bit more about yourself?
Okay. So I'm Rossi. Officially, I'm Lieutenant Colonel Edujemfi.
Okay.
I am a general surgeon, and I'm currently the head officer in charge of the emergency department in 37 Military Hospital. If my interest is into people that, it's instance where people are almost dying and trying to do something to bring them back, but I'm a trained surgeon in South Africa.
Okay.
I do my routine things in 37, and I've been working with the Ghana Armed Forces for the past 11 years now.
Okay. So you do you operate people in the army or people outside as well?
Generally.
Yeah.
So I do surgeries for both uniformed personnel and civilians.
Yeah.
And I think in my career and back to Ghana, I've operated more on civilians than uniformed personnel.
Okay.
And most of the things that we do, basically, especially even on peacekeeping, when you're on a mission, we treat more of the locals who are civilians than even the uniformed personnel. So I do surgeries.
How is that?
Because, when you are in somebody's country, you need to kind of find a way to be accepted. And, health is very important. So one of the ways to get them to accept you is to try to provide health care for them. And so we do that a lot. We call something CIMIC program in the army, that we actually engage people who are in the communities where we find ourselves working in peacekeeping or peace enforcement, and to be able to help them kind of be better in terms of their livelihoods. And so we see them a lot. And there are days that we even dedicate our clinics for locals, as we call them there, to just see locals and then help them. So that is that. And then in Ghana, Noted 7, even though it's a military hospital, we see civilians.
Okay.
So, and there are more civilians, like there are more than 100,000 times than us.
Yeah.
So basically in that regard, we also see more civilians than uniformed personnel.
Yeah.
And so for that reason, that's why we end up seeing.
You talk passionately about your field.
Yeah.
What do you... I can see it, you know what I mean?
Yeah.
And what do you love about it?
So which one? Two careers. So.
I mean both, because let's combine both.
Yeah. For medical wise, I think, funny speaking, I'm not the type that grew up thinking, I want to be a medical doctor.
Right.
And so in my medical school interview, when they asked me why I want to be a doctor, my answer was very simple: that there's job security and the money is better than other professions.
Yeah.
But ideally, I wanted to do physics and math. So I actually was quite good at that. And medicine came up because some opportunities that came for me to do that my parents felt like it wasn't the right chances or things to do. And so I did medicine. But in doing medicine, it still fits the same thing because I love to do things that kind of transform or change people's life.
Yeah. And
medicine has been one of the things. And it's the reason why I have a lot of interest in what we call acute care surgery.
Okay.
And even though it's a pathway in general surgery, what you normally do is people who are like really sick. So either they've been stabbed or shot,
right,
or have some form of infection inside their tummy or any part of their body that need to be operated on. That's what I usually do.
Okay.
But in addition, other things I put with cancer, hernias, hemorrhoids, I also do those things.
Okay.
But it's all goes to help people. Yeah. And anything that you see somebody come screaming, shouting, the next day they are quiet, walking around, don't have any issues. Actually nice to see that.
Yeah.
And it doesn't even have to take the person to come and say thank you, but you know what you've done and it makes you feel proud about yourself. Yeah.
Nah,
and
true.
I mean, in the military, I mean, it's I think it's until recently that the idea of people being patriotic, it seems to be dying out, you know. But for me, I always say that you must be proud of who you are as a person. And I'm a very, very proud Ghanaian. And I feel to be able to serve in the military actually kind of optimizes my pride as a Ghanaian.
Right.
And so when I find myself in there, I need to do everything that represents me very well in my country. Yeah. And I don't see any better way of doing that than being in the military. So it's like when it comes to those things, I don't take it for granted at all.
Okay. It's like you're gonna be there. Are you thinking to be there for a long time? Or?
In the military?
Yeah.
We'll see about that.
Yeah.
We'll see about that. I think, you know, life happens. And so as you go along, you find probably there are maybe other ways that you can do more.
Yeah.
Or if this is the place that you think you can do more.
Would you encourage people to get into the military?
Get in the military. Yes, of course. I mean, if it's something that the person is passionate about. Unfortunately, in Ghana, things have become more of employment. So you find people wanting to join because they just want a job. But I think that if people are to join the military for the sake that they want to protect their country, then from that point of view, yes. Because if somebody comes in for a job, then those are the things that leads to corrupt acts and indiscipline. And for military, those are the two things that we eschew a lot, like indiscipline and corruption. Yeah. And so if somebody would come with the mindset that they love their country and they want to really do something and, I mean, God forbid, die for their country and things like that, then yes, of course.
So people should do it for the passion,
I think so.
Not necessarily for the money.
I think so. Because, I mean, if it's about being a millionaire in the military, then that one I can't guarantee that for you. Maybe you may have to look for other options. Yes, but you know
that's what President Nanado said before, and then he got into trouble about the teachers. You know?
No, but I mean I mean I'm a lieutenant colonel.
Yeah,
I'm quite senior in the military, and I don't have 1 million. So, and I'm not just a regular military person. I'm also a general surgeon, but I'm a senior specialist. And I don't have a million sitting down there. So I don't know how you.
It's a reality. It's a fact.
And think that you want to come and have 1 million,
Yeah.
there. But you'll be comfortable. That one definitely. You would have what you need in life. And the other things that come with, yes. But it boils down to the reason for joining is the reason to do something for your country.
Okay, so today let's talk about breast cancer. But before we dive into breast cancer, I want us to, I want you to educate us a little bit about cancer in general. Then we can get into breast cancer.
Okay.
Because cancer is broad, isn't it?
Yes. So the idea, if we say cancer, it frightens a lot of people. And I think as the way our society has evolved, taking Ghana in particular, you realize that when we mention cancer, it's like you've been sentenced to death. And people literally freeze. And those that are panicking will start panicking. And those that are seeking for spiritual support will seek spiritual support. I am a Christian, and I believe that what the Bible says about for lack of knowledge my people perish. It's a fact. And I mean, everything that I think the Bible says is a fact. Information is light. And when you get information, it should shine your path to let you walk on it. And so when you talk about cancer, even if you find yourself to be the unfortunate person to have been diagnosed with it, you should take it as light and you should act on it. Basically, cancer is just a cell in your body that is behaving abnormally.
Okay.
And because it's behaving abnormally, it does all kinds of weird stuff. Either it is dislodging from where it started and going to other parts of your body. And because it gets other parts of your body and it doesn't belong there, it even behaves abnormally more. So it can grow into things there. It's not restricted. It's like having a recalcitrant child. They can do anything and keep surprising you with all the diverse ways that they want to misbehave. And that's how the cancer cell is. And so as it does that, it's growing abnormally. It's moving anywhere it wants to move. It's entering any space they want to enter. And that's the long and short of it. So in solving that, it's about making sure that you don't allow it to now misbehave to a certain point. It's like you have a child, 5-year-old, who keeps throwing things at guests who come into your house. That is misbehavior.
Yeah.
If you don't keep it in check and the child feels they can just keep throwing, they can keep throwing. Over time, they do worse things. The next thing, they feel they can do whatever they want. The next thing, they've taken a gun. They're probably shooting everybody in the house. By that time, it's too late to do something about it. And that's how you can see cancer to be.
Okay.
So if in the early stages, it is seen and is diagnosed, then something can be done.
Okay.
And most of the time, cancers that are found early are curable, which means that it can be cured and you can live the life that you want. The problem is when it is not found early.
Okay.
And when it's late. And that one, it's either dislodged and in other parts of your body, or the area that it is, it has grown into things that makes it difficult to cut out.
Okay.
That is a problem. Because for that reason, you can't, let's say, cut cancer that will cut the main artery in your body that takes blood everywhere. So if you do that, then why are you taking the blood too? Those kind of instances. But just remember that it starts from somewhere. So wherever it started from, if it's found early, then that problem will be prevented and it can be solved. It's the reason why it's important to do screening.
And these are all sort of cancer. Any sort of cancer, when
cancer
it's found early, it can be cured.
Yes.
Right.
So it comes down to the point of screening.
Okay.
And in most countries, they do that. I mean, we're talking about UK. And in NHS, I mean, when it comes to things like colorectal cancer, things that they think can kill people, or things that they think when they become complicated, it costs a lot to manage. They do these things to prevent it from either making the patient's life quite worse, or reducing the cost at which it will be used to treat if it's later. So they do screening for a lot of things. And so that's why in our side, we don't have that system where we have screening systems set up by the state or the Ministry of Health or the health authorities.
Yeah.
So as individuals, we need to do that. So we can go through case since we're talking about cancer in general. For example, if you take colon cancer, for example, if you turn 55, 56 to 60 years, it's important that you consider whether you do colonoscopy or, which is a camera that they pass through your bum up and look at your whole intestine, the big intestines, and see there's no problem in there. Or before 60 years old, you do what we call stool or cord blood.
Okay.
They take stool samples, they look for some blood in it, and if there's blood, then you now do colonoscopy. Or you do the colonoscopy that earlier I said. And you do that every 3 years. Because cancers normally don't just suddenly appear.
Okay.
They take time to grow. In some situations, about 5 to 10 years before it starts manifesting.
Okay.
So if you catch it early in its tracks, you solve it before it even becomes a problem. So that is about colon cancer. From 60 years, if you're a 60-year-old person, you should be getting colonoscopy every 3 years so that immediately it appears, we can see that. If you take breast cancer for a female, and that's the thing, most of the time, we think breast cancer, we talk about only females.
Okay, so let me just then, since you've already mentioned breast cancer, let's talk about breast cancer itself. Like, how can breast cancer occur?
Okay, so all of us have breasts.
Okay,
male, female, we are all born the same. So when you look at even and here I digress a little bit. Look at boy, girl growing up. Our chests are the same until the woman hits puberty. Yeah. Then there's transformation. What is causing the transformation is the hormones that they've started producing. Okay. So they produce a hormone we call estrogen and progesterone. And these two hormones are what cause the development of the breast of the woman. Okay. So you can see that there's suddenly that area, that dark area around, it's like a scarred area around the nipple. Okay. We call that nipple areolar complex. Okay. That area becomes a little bit thick and heavy, and then it's like it's bulging, and then the other breasts now start rallying around it to make it a little bit more presentable later. So that is how it develops. It's the estrogen in the woman. Men also have estrogen. Okay. Except that the place where the women get about 90% of their estrogen is from their ovaries, which men do not have. Right. But we get estrogen from our adrenal glands, which is a certain small organ sitting on top of our kidneys. Okay. So that's where we get ours from. It can contribute to we getting breast cancer because estrogen plays a major role in breast cancer. Okay. So now, for this reason, the point I want to establish is that both men and women get breast cancer. Initially, we used to say that males getting cancer usually was related to whether you have a family mutation or hereditary. We call that BRCA.
So wait, males, females get breast cancer.
And males do get.
Even though we don't have breast.
We have breast.
Do we?
Yes, we have breast. So what we see here on our chest is breast. Okay. But then we have the milk production factory. Okay. Which is inside this one. And for women, that's what develops. Okay. So that they will be able to feed a baby. Right. For males, ours do not develop. Okay. Ours stays in the rudimentary stage as it is.
So what I can call this breast. Okay.
Yeah, so all of this is breast, but there's a production site in it that develops in the female. Okay. So that's why female, when they get pregnant, their breasts get bigger. When they're about to menstruate, their breasts get bigger. Yeah. Because the production site is always kind of prepared and gets the body ready that, okay, maybe it's about time for you to feed, so let's get you ready. Right. Men, we don't go through that phase. And so ours stays as it is. Okay. So, for example, you can have a baby that because the mother's estrogen crosses the placenta into the baby's blood when they are inside the mother's womb. When they are born, you have babies producing breast milk. It disappears after that. Right. And it doesn't matter whether it's a boy or a girl. And the fact is that because of the estrogen from the mother's side is producing that. So even at the baby level, as young as that thing is there. Yeah. But for it to become big and develop, is based on the increased volumes of the hormones that impact in the case of women. So both of us have breast.
Okay.
The development is what varies. We've operated on 2 males with breast cancer.
Oh, really?
Yes.
Oh, wow.
Which means that it's something that we have to always think about and consider. And one thing that we've talked about breast cancer, it's always the women. It's more common in women, and being a woman is a risk factor to develop breast cancer. But we shouldn't forget about the males.
But it doesn't mean that it won't happen to the men.
Exactly. We shouldn't forget that. About 1% of cases are males. And probably, as I said, to have 2 in a short period of 4 years is actually a lot.
So what causes breast cancer then?
So first, we talk about risk factors or things that increases your chance of developing breast cancer. So the first thing that we can talk about is, as I've said, being a female. So being a female is a risk factor. So a female has a higher risk of developing breast cancer compared to a male.
Right.
Okay. As you grow, cells in your body start misbehaving. And so the chances of you developing even cancer in general increases. Okay. And the same thing applies.
So that's natural.
Natural.
Okay.
Applies to breast cancer. So that is the second thing. So sex or gender and then age.
Okay.
The third thing is family history. There are some people from families that have high risk of breast cancer, and they have what we call the BRCA gene mutation, BRCA. It can be 1 or 2, but I will not go into that. Okay. We're not having a medical academic thing here. So when you have that mutation, then your chances in that situation, you have about 50% chance of developing breast cancer. Okay. Generally, the risk of developing breast cancer is about 1/11 in a population. But in that situation, you're talking about 50%, which is like 1/2 chance of developing breast cancer. So that is there.
So it's genetic?
Genetics, yes.
Okay.
Then the next thing is obesity.
Okay.
There's a strong evidence to support the fact, and there's a trial called Umbrella, like Umbrella Chinier trial, that showed that obesity or high BMI or overweight.
Can you explain the BMI to our audience as well?
So BMI basically is that for every height, there should be a weight, or every weight should be an assigned height. So if your weight compared to your height is too much, then we say that your BMI is high. Right. So in terms of mathematical sense, what you do is that you check your weight in kilograms. Right. And then you check your height in meters. Then you square your height. Those that are still weak in math, you multiply the height by itself. Right. So if your height is 1.5 meters, you multiply 1.5 meters by 1.5 meters. Yeah. That is a squaring the 1.5 meters. And then you use that figure to divide your weight. So for example, if my weight is 80 and my height is 2 meters, then I'll multiply 2 by 2. 2 by 2 is 4. Then I'll use the 4 to divide the 80. Okay. That is 20 in the end. So my BMI is 20. Right. So that's how you do the mathematics.
Okay. It's to you it's very simple, but to me I'm a bit lost. But I'm sure the audience going.
It was too much.
I did not get it, but maybe.
Oh, that's why I've broken it down like that.
That's a lot. That's a lot of information right now. Oh, but maybe I'll watch the video again. Because even if you repeat it right now, I'm not sure. Okay, all right.
So,
I was getting it in the beginning, and then my mind went shambles.
God, that's the moment. So basically, it's your weight, right? Okay, and you divide by your height. So let's think about that. Your weight over height. But your height, the figure you get for your height, you multiply by itself. Okay. So if my height is 2 meters, then I'll use it to divide my weight. And my weight is 80 kilograms. I use to divide my weight. But I have to multiply my height by itself before I use it to divide. So we say weight is 80. Now height is 2. So I'll multiply the 2 by itself to get 4. Then I'll use the 4 to divide the 80. Okay. So if I divide 80 by 4, that is 20. Okay. Then it means my BMI is 20.
Okay. So in short words, in just like 3 words,
yes.
How did you put all these things together? in a show, like
So
4 words.
in 4 words.
Yeah.
So your weight,
Yeah.
you divide it by your height times itself.
Thank you. Thank you so much.
There are actually charts
Yeah.
that you can use. So there are BMI charts, some in like pie chart form that you know your weight and you know your height. You can arrange on itself and it can tell your BMI. And there are actually apps that you can use to also calculate your BMI. The only thing you need to have is your weight and your height. In kilograms for weight and in meters for height. And then that's that.
Okay.
So
yeah, that's the BMI.
That's the BMI. So any increased BMI, overweight, obesity also increases the risk of breast cancer. Then you have other people that they may not have genetic mutations necessarily. We call that familial. But for that particular family, they are known to have certain types of cancers.
Okay.
So ovarian cancer, prostate cancer, gastric cancer, which is stomach or colon cancer. Those family, we may not have any specific mutation they have. But because you have that consistency in that family, then the person has a higher risk of developing breast cancer.
Okay.
Another thing is hormones. You know, naturally, a woman is born with their eggs. The eggs produce the hormone, as I said, when they hit puberty, start producing it in high volumes. And then when you get to menopause, it stops.
Right.
Some people still take hormones, either by injection or by mouth. Okay. Some people it's for contraception. Others, it's so that they will delay menopause.
Okay.
We call that one hormone replacement therapy.
Okay.
Those group of people also increase their risk because, as we've explained, it means that the longer you are exposed to this estrogen and progesterone, the higher the chance of, getting breast cancer.
Okay.
So who are these categories? First person, somebody who has never given birth before. Because the whole period of pregnancy and delivery and all of that affects your hormone cycle. Okay. So there will be a time that you may not even have, at the time of pregnancy, the hormones, the estrogen, at the time of delivery, when you give birth, those estrogen and progesterone levels drop. Yeah. So that you can produce another one called prolactin to have more milk. Okay. So that's what happens.
Okay. So the milk replaces the hormones.
Exactly. So for that period, you don't have exposure.
Yeah, I get it.
So if you never give birth, as compared to someone who, let's say, have had 3 children, then you can see that there are intervals where the one with 3 children was not exposed to the hormone. So that's why we say somebody who has never given birth before has a higher risk of breast cancer. Somebody who starts menstruating early. So if you start menstruating 4 years before other people, then you have been exposed longer to the hormone than the other person. Somebody who now takes this hormone replacement therapy to prolong or delay their menopause also have a higher, an extended period of exposure. And all of these are the reasons why when you have a prolonged exposure to the hormone, then your chance of having breast cancer also goes up. Okay. So these are the major things. One last thing is lifestyle. And the key thing here is smoking. And smoking also generally increases the risk of cancers, and therefore same thing apply to breast cancer.
Breast cancer. Okay. So could the causes also be early signs as well, or what would be the early signs of breast cancer?
So most of the time, the early sign in breast cancer is feeling a lump in your breast. And talking about a lump, maybe I would talk about the development of the breast in a woman in general, so that we don't scare people. Because there are times that you can have a lump in your breast and it's not a problem at all. So a woman's breast goes through 4 phases. Again, I'll mention the word, but I'll explain. We have the first phase we call the proliferative, the English word proliferative, something dividing or growing at a very fast rate. And that phase normally happens from the time where you hit puberty to about 25 years old. You expect the woman's breast to develop. So as you said, the chest is like our chest, and then suddenly, boom, it starts becoming bigger. Now, because things are growing in the woman, it is normal for them to have lumps in the breast.
Okay.
And we call that fibroadenoma. So you have a lot of times that a woman with develop fibroadenoma and go to the hospital. And since it's educational, one thing I will say is that any woman who is less than 25 years old and you have a lump and they tell you it's fibroadenoma, it doesn't need to be taken out. Because when you get to 35 years and going, it will start disappearing. The problem is, if you didn't have any lump in your breast, and let's say from 35, there's a new lump, then we are worried. But from puberty to 25, it is expected that you develop lumps.
Okay.
It doesn't mean that we should be negligent of not finding out
whether it is a breast cancer or it is normal.
If it is a fibroadenoma, less than 25 years old, there's nothing to be done.
So how would you know it's not breast cancer?
It's how it feels.
Okay.
So when you examine the woman's breast, and we'll talk about examination again when you're talking about how to assess it. Normally you use your hand, you feel for this part which is much more sensitive. Like if you put here to your chin, you put here to your chin, there's a difference in how it feels. You use the tip of it, which is soft and padded, and then you press the breast against the chest.
Okay.
And then you feel it, you divide the breast into 4, and then you feel each part of the 4 quadrants against the chest to see. If there's a lump, you'll be able to feel it.
So is it best the person examines themselves, or can someone examine for them?
So ideally, there's evidence to show that if women self-examine themselves, they are able to actually pick it almost the same way as when it's done in a hospital.
Okay.
And the fact also is that they know themselves. You know yourself. You know when something was there, when something was not there. So that is the caveat here. So back to what I was saying. When you feel for the lump, in fibroadenoma, it is quite discreet. It feels very mobile. We call it like a mouse because it quickly moves around. So you feel you press it and it has skipped to another place. If it's a mobile, very discreet, doesn't have any rough, funny things, not attached to your skin, and it doesn't show any pulling of your nipples. Your nipple doesn't get pulled in because your nipple is supposed to stand out. Sometimes to see that the nipple is pulled in or the nipple is bending into the breast itself.
At all times.
It's supposed to stand out.
Okay.
It can deviate. It's expected. One nipple can face here, the other nipple can face here. It's expected, it's normal. But if it gets pulled into the breast,
then there's a concern.
You need to get it examined. It may not be it may not be cancer.
Yeah.
But just so that you get
to make sure.
Yes.
Yeah.
So in this situation, this lump that we are describing called fibroadenoma doesn't cause these kind of things. It doesn't cause depression on the skin of the breast. It is not something that is just lying down there and kind of making the breast feel funny or deformed. It just moves around in the breast. That is how it will feel.
Okay.
And so in that situation, you don't have to worry about that. And if you're less than 25 years old, more reason not to be worried.
Okay.
Then the breast goes through the next phase that we call the cyclical phase, and which is related to your menstrual cycle. So you realize that in women, they will say that, as I said earlier, before they menstruate, they feel the breast is becoming big. In some situations, it's even a little bit painful. And it doesn't have to be both breasts. It can just be one breast. It's normal. And it's because of the hormones. The hormone level going up and coming down and swinging, causing all those engorgement and pain. And so that is also expected. And that happens within the period that the woman is menstruating. So it means from the time of puberty to menopause.
Right.
Then you have what we call the involution phase, where the breast now starts collapsing. We say that the wall starts crumbling down. And that starts from the age of 35 to about 50 to 55. That phase, all the things that you formed from puberty to 25 years old start wearing out. Because now the body is preparing itself towards menopause. So as it's preparing towards menopause, the milk production site start getting cleared out of the system. In this case, the breast. Because at menopause, you're not going to feed any child. So
and that will be what, from 35?
From 35. Right. It happens between 35 and 50 or 55.
Okay.
So as the body starts clearing the milk production side, maybe the tube, which is the pathway that the milk passes to come to the nipple, and there are about 8 to 10 openings on the nipple where the milk comes out. They all start thinning out and they start getting engorged. And so they end up keeping milk in them because they are not stiff and straight anymore. They're a little bit torted, stretched, and because it's getting, resolved.
Yeah.
What happens in that situation is that then you are going to have a lot of collections in the breast. So in that situation, the pools of milk that get stuck in the breast, and therefore the changes that is causing in the breast is more like scarring. We call that fibrosis in medicine. A little scarring also going on.
Right.
Lead to the breast become a little bit lumpy. So you may not necessarily feel a specific mass in the breast, but then it is more lumpy, feels like a doughy feature of it.
Okay.
And at that time, it's also normal. Even that time, you can feel collections, we call that cyst, which can feel like a mass. It's also normal.
Okay.
One thing I said about the nipple getting pulled in and all of that can also happen in this phase. It's also normal.
Okay.
So when these things happen, the key thing is for you to just get a checkout and make sure that what is going on is not a problem.
Yeah.
So that is what happens between that age. And then the final stage is the menopausal phase, where you don't expect any milk production tissue. So the whole breast will get filled with fat.
Okay.
Which means that if there's no milk production, the milk is not growing, there are no pipes there, then we don't expect you to have cysts or collections of milk in the breast. If that happens, we are worried.
Is that when it goes saggy?
Yes.
Okay.
It becomes droopy. So when that happens, then we are worried. When you start having masses or lumps in it, we are worried because we expect it to be.
Because it shouldn't be there.
It shouldn't be there.
Right.
Exactly. And so if it's there, then we are worried.
Yeah.
And so at that time, we shouldn't expect any lump or anything at all happening there. And these are the phases. So in knowing and understanding these things happening, then we can actually follow it up and see that, okay, so if I don't have a mass in my breast and I'm 32 and suddenly I can feel a mass in my breast, then I need to get it checked. If my nipple at menopause is producing milk, when I squeeze my breast, there's milk coming out or there's liquid coming out, then I have to be worried. Because the time where we expect there to be collections is supposed to be between 35 and then 50 to 55 or before, from 35 to before menopause.
Okay.
And even that, the collections, when it gets to the point where maybe it becomes so big that we have to draw, we must make sure that it is not bloody or it's not thick.
Right.
It can be any color. It can be blue, it can be green, it can be white like milk. We are not bothered.
And it's normal.
But if it is bloody or thick, then we are worried.
It's a concern.
Even if you are not menopausal or you are a younger person, then we have to raise a lot of concern. So these are the things that we look out for when we talk about how do you therefore find out whether there's a cancer, breast cancer.
Does these signs apply to men as well?
Yes, the same sign. I mean, men, if you're a man, as I said, unless you are just a baby now whose mother's estrogen have crossed their placenta and therefore is making you produce milk at a very tender, very, very young age, maybe day 1, day 2 of birth. If you are an old man like me and all of a sudden your breasts start producing milk, then we have to be worried. If you are at this age and we feel our breast and there's a lump in it, you have to really worry and get
You're not old, by the way.
I'm comparing the day old, So basically that is that. When you look at the next step where you felt a lump, or at times the lump may be very small, you may not even be able to feel it.
Okay.
And in some situations, the cancer may not be a lump. It may be just a nipple discharge.
Okay.
In some situations, it may look as if it is just redness of the skin with no lump in it. So all of these things can happen. And most of the time, we may say that, as for breast cancer, it's not painful. You can have breast cancer that has pain. Like this redness I'm talking about will give you pain. But on talking about pain, I would also need to stress that about 70% of women in their lifetime will go to the hospital and complain of breast pain, and it will not be related to cancer. Most of the time, it's because their bra size is too small. They need to change their bra size.
Okay.
And they just probably be put on pain medication. In some situation, maybe the pain is not even in the breast, it's in the chest. And at times in the ribs. And also just you need pain medication. So I want to stress on that. But it does not mean that you cannot have pain with breast cancer. It is possible to do that. And so the next thing in this case that you go for is to do a mammogram or ultrasound. Usually when you are less than 40 years old, you do breast ultrasound. And the reason is that because you have the tissue, which is the milk production tissue in your breast, it makes it look bulky. And mammogram will not be able to pick it if there's a problem. So ultrasound will be the best thing. However, when you hit 40 years old, then we have to do both a mammogram and a breast ultrasound. In addition, if somebody is on hormone replacement therapy, mammogram will not help them.
Okay.
They'll do a mammogram and it will not do anything. So for those people, they need to do an ultrasound.
So that is not too confusing for people. Everything that you just said now, if you want to be sure, can they just go to their doctor and then the doctor maybe will advise them or direct them to the right place to do this?
The key thing is that for a female, it is essential that every year you do one of those or both. So if you are less than 40, you do ultrasound. Every year. So mostly from 35 going, you must consider screening for a female. If you are more than 40, you do ultrasound and then you do a mammogram and then they will add an ultrasound to it. If you are postmenopausal, where you don't expect any breast tissue at all apart from fat, the mammogram will be adequate. And that is what to put it in a simple form. And that one, you don't need to see a doctor before you do it. Because most of these diagnostic centers do them. The only thing is that make sure you do that at the right diagnostic center.
Yeah, exactly.
A lot of people have all kinds of things around too these days.
Yeah. So if you go to the wrong place, then what you have?
And unfortunately, you end up having either wrong imaging, wrong diagnosed. Everybody's looking at it, doesn't even know what they are looking at. And all of that. And it's quite common in Ghana now. So if you're not sure again, this is something that you can ask your doctor or somebody in the health system sector to help you with the right place to get.
Is there any way we can avoid breast cancer?
Avoiding, no. No, you cannot avoid. You can, as I said, generally in the population, not doing anything, just living your life as a woman, you have about 9% chance of developing it. You understand? Generally. And so the key thing here is that at a certain point, because you can't stop growing, you can't stop being a female, you can't stop being exposed to the hormones. So you can't say you are going to avoid it. You can minimize your risk. Making sure you eat healthy. I mean, if you're smoking, you stop smoking. Checking yourself and making sure you're in the right weight limit per your height, as we discussed by BMI. Those are the things that you do. And then in addition, you do screening at the ages that I've said. From 35 years old, you need to consider doing screening so that even if it's there, you catch it early. But to say that you are going to avoid it, that one, unless God comes in and say that you have excluded you from that, you cannot avoid it.
So everyone has 9% chance of getting breast cancer.
Every female, yes.
Every female. Is it fatal?
So it's only fatal when it's neglected. It's only fatal when it comes in an advanced form. And in that case, then we say that you are not treatable. And that's what used to happen a lot. So like I had this client that I was seeing, and she had a lump. She decided to pray about it. And I always say that, that's why I said a caveat that I'm a Christian and I'm Holy Spirit filled, baptized Christian. And so I believe in miracles and the things that God's power is able to do. But we have to apply wisdom in the things that we do. Because the Bible says that in all that two things you must get is wisdom and understanding. And so
common sense.
Exactly. I was just actually being polite.
Yeah, I know.
I was trying.
I know. That's why I had to drop it for you. I knew where you wanted to go.
Stay here, you know. But basically, the idea is that you have a lump, at least get it investigated. So she disappears. Disappears, goes, prays about it. If your faith is unable to let your headache go away, like really, frankly speaking, headache, you can't feel, you can't touch, you can't see. It's just there.
Yeah.
You can't have faith for it to disappear.
Sensation.
You want to have faith for a mass that you can feel to disappear. You know, I mean, I think we have to apply that thing you said.
Common sense. That's why it is.
So it doesn't work like that. Anyways, though she went, prayed about it. It didn't work. So she came back. We did a biopsy now. We found out that it's a cancer. Now it had gone up in terms of size. So she came, we did a mammogram initially. She was a little bit older. Did a mammogram for her. It was clear. If you look at the mammogram features, it was clearly suggestive. So in that case, the next thing you do is biopsy. Yeah. So we did a biopsy and it confirmed that it's a cancer. You know, unfortunately for her, she had the aggressive type. And maybe I'll speak a little bit about that as we go along. And I explained to her, okay, so we need to go through treatment, you know, certain regimens and everything. She says yes. And she's a soldier's wife. So clearly, the things that should have gotten done in test service, shouldn't have been paid for most of it. So now it's not even an issue of finances.
Yeah. It's belief.
As I sit here, I'm yet to see her.
It's really sad though, where, you know, it's good to have faith, you know, it's good to have something to lean on to, you know, but most times, you know, we should be able to, as we said, use our common sense, you know, because if sometimes if you go to your pastor, and it's so sad, you know, our brothers and sisters run to pastors for everything. You know, sometimes some of the things need medical attention. It's not everything that you need to go to your pastor, because, you know, if it is medically related, you'll be able to see, you'll be able to know if you know.
Yes, I mean,
if you
for
check
example, and again, I'll be making reference to the Bible a lot, but the Bible talks about how people pray and their prayers are not answered because they pray amiss. So if you think you are spiritual, you know, you are godly and all of that, why don't you get a diagnosis so that when you go to God, say, you know, exactly, I have this problem.
Exactly. Yeah.
Do you understand? This is my problem. God, deal it for me. But if you go and just, you know,
pray. No, you cry. You don't know what you are talking about. You don't know what you want.
Yes.
And then you are praying and making noise about it. You know, I feel like it's really sad sometimes, you know, to see things that could have been resolved.
Yes.
You know.
And this woman, I'm expecting. I know definitely she's going to come back because her husband is still in the service. She's going to come back. And by the time she comes, it will be too late.
Hopefully, I was going to say, hopefully it won't be too late.
No, I mean, it's been before. This is 2022. And in cancer treatment, every 6 months, if the person disappears and comes back, after 6 months, we have to restage you because we expect to have changed. Yeah. And so 2 years and counting.
Let's talk about the surgery. What are the risks of undergoing like breast cancer surgery? Okay.
So basically, when we talk about breast cancer treatment in general, we have the surgical treatment and then the non-surgical treatment. And the non-surgical treatment involves what we call radiotherapy, where we put like a stronger X-ray, we direct it towards a certain area in your body, in this case your breast, and then we let it heat and basically cook the cells there. Or hormonal or systemic therapy. Okay. So the systemic basically means that we're giving it through your veins, or you're taking it oral or in your mouth, and then it would disseminate into your body, your whole body. Okay. So that one you can have what we call a chemotherapy, which I think most people know, injections, then people lose their hair and all of that. Or you can have hormonal therapy, where we take tablets.
So wait, you know when the one that people loses their hair,
Yeah.
that does it have anything to do with the breast cancer as well?
Yes, it's the treating the breast cancer that leads to losing the hair. Or treating cancer in general.
So it's in general, like cancer in general.
Some of the cancer medications would cause hair loss.
Okay.
And so it is expected. So some people some women will just shave their head in anticipation of that and then do that. And I mean, it doesn't change anything. I've had clients who are celebrities and they've had breast cancer and they've been on systemic therapy and they shave their head and they wear weave on and they are happy to go because now, I mean, most women are wearing weave on anyway. So it doesn't even make a difference. So it doesn't change anything about you. And so those are the first things we talk about, either hormonal therapy or chemotherapy. And then the other called biologics, but we'll not worry ourselves with that. And then the radiation. It depending on your stage that you come in. You may need all of them. Some people may not need all of them. Some people may just need the surgery and then the hormonal therapy, which is tablets that you take for a period of time. So that is the non-surgical.
So depending on where you are at that moment.
Yes, depending on the stage of your diagnosis. If it's early, for example, you get the surgery done, you stay on the hormonal therapy, depending on the type. Or in some situations, you get a chemotherapy done, you get a surgery done, you get some more chemotherapy, and then that's the end of the story.
Right.
So it depends. If you come late, then that one, there's very little that can be done. So that is that. The surgery itself, we look at two main types. There's one that we say we are conserving your breast. So we are operating and taking out the lump with some things around normal tissue, normal breast tissue around it, and sending it away. Or we are taking the whole breast. Again, if you come early and it's small, we can conserve your breast for you. You understand? Because then it's not so big to cut everything away. So we just take the mass or the cancer with a little bit of normal breast around it, and then we remove the breast. And then you continue with the therapy as I've described earlier. If it's late, or if there are other features that is worrying, then we take the whole breast away. Even that, for younger people or people who are not even young per se, but are interested, we can reconstruct the breast for you. So you can get breast reconstruction. And again, I've had clients who have gone through this and they've had their breast reconstructed. So people say, okay, so if you are taking the whole breast, what about my nipple? In some situations, we can spare your nipple. Take the whole breast, leave your nipple, and then reconstruct it with your nipple. In situations where your nipple must go, we can reconstruct nipples for you.
So you make a whole new
nipple, a whole new breast.
So if you have a breast cancer, depending on your stage, it's not, if it's not too late, you can actually have, like, you can get another nipple or another
we can
breast.
save your original nipple,
right,
and take the breast away, but leave the nipple, and then put in a new tissue to reconstruct it. And the reconstruction can be from your own body or from prosthesis. In this case, most of the time we use silicone. But we can take fat from this side of your tummy. We can take muscle from the back. You know when you hold your waist and you press, that muscle that pops up this way, we can flip that and reconstruct breast for you. There are so many ways that reconstruction can be done. So the fact they have breast cancer doesn't mean that you're going to lose your breast. And you know it's important for the women. And so that's why I stress on younger people, because maybe at a certain age, people don't really care. But for the younger clients, they need to understand that breast can be reconstructed. And somebody like Angelina Jolie, she has family or hereditary issues with breast cancer and ovarian cancer. That BRCA gene that I mentioned earlier. So she took off her breast before it even become cancerous. I'm not saying we should do that. It's not advisable to do that, but it's a choice and a preference that you can decide that, well, I don't want to go through this thing and struggle
just to avoid the risk and all that.
If you have the genetic predisposition in this case per se. And so what she has now is reconstructed breast. You understand? So it can be done.
So again, it's not, because I'm sure people are scared to even find out. Because they think, oh, that's it, then, they are dead or something like that. So these are measures put in place for the, if we're able to check, and if you have something,
Yes.
you know, so it's good to always check, isn't it?
Always check. And you see, for example, if you found early, is like I've known people who are breast cancer survivors, and they've lived more than 20 years and they are still living.
Wow.
It's not a sentence to death.
Percentage-wise, how many people survive from breast cancer?
So if it's found
breast cancer
early,
surgery,
if it's found early,
Yeah.
and the right treatment is done, the chances of survival for the first 5 years, especially if depending on the type of breast cancer you are talking about and the treatment that you get, if you get the right things done, you expect survival to be more than 90% in the first 5 years. In this case, you're saying that if, let's say, 100 people get breast cancer and you operate on them, give them the right treatment and get the right care, 90 of them will survive after 5 years. And even when you look at even specific types of breast cancer, we call something the luminal A, that you put them on hormonal therapy, and they stay on hormonal therapy for 5 to 10 years. The chances of survival for 10 years in some situations are about 100%.
I see. Wow.
So if you find it early, it can be treated. If you don't find it early, then we now have to give you, 2 years, 1 year, 6 months, and all those complicated things. For example, if you come with lung complications, with fluid collecting around your lungs or masses in your lung, we can't give you more than 4 months because it's late.
Yeah.
And these are the dynamics of it.
So when after treatment, can it come back?
Yes, you can have recurrence.
Okay.
You can have recurrence. And so in certain jurisdiction, what we do is what we call the recurrence score, where we can take your blood and check for certain proteins. We call that genomic testing.
Okay.
And check how high your score is. And so if your score is high, then we have to do things to prevent the recurrence. So for example, as I said, with the one that we put the person on hormonal therapy, if you know that the person recurrence score is a certain figure, for example, and you put them on hormonal therapy, let's say you said that you are putting on hormonal therapy for 2 years, the chances of the tumor recurring is about 30%. If we put you on it for 10 years, for 5 years, the chance of it recurring is about 10%. If we put you on it for 10 years, the chance of it recurring again is almost zero. So those are the things. So the recurrence is dependent on the treatment that you get. Again, how early you come. Because if you come, for example, and the cancer has grown and attached to your chest, right? And then we do chemotherapy, move it off your chest, and then we operate on you. And that one, the whole breast is going. Yeah. You take the whole breast away. If you don't get radiation, recurrence is high.
Right.
You understand?
Yeah.
So those are, and that's an example of the dynamics.
Okay.
And that's why I keep stressing on, if you don't get the right treatment, if you don't come early, those are two key things that will determine recurrence. And then in addition, the type of cancer that you had would also determine that. So if you're not lucky, you get the worst form of breast cancers. And generally there are 4 different types. You get the worst form of the 4. And you also dilly-dally with your treatment. And unfortunately, you find yourself in the hands of someone who also doesn't do the right things. Then you are in trouble.
So, in a short term, examine yourself, get it checked.
Yes.
Get yourself checked.
Yes.
Early, seek help early, and you will be treated.
Yes, basically. So self-examination is important. As a woman, every morning when you are bathing, you stand in front of the mirror. When you are checking yourself and how fine you are, feel your breast. Examine it. Press it against your chest wall and gently rub it with the I was going to use medical terms, say the distal part of your fingers, but the padded part of your fingers. Feel it against your chest wall. It keeps a mental note. The next time you feel it's different, you know. Do that every morning. If you find something, ask for help. If you feel it and there's nothing, do investigations every year from the age of 35. Every year, do an ultrasound. From 40, they'll add a mammogram to it. If they find something, seek help. If you find something early, you can pray. Believe God. Let your faith become big. But
seek help.
Seek help
as soon as possible.
Yes. If you are less than 25 years, from puberty to 25, and you find a fibroadenoma, you don't need to take it out. Unless it's very big and is disfiguring your breast. But otherwise, you don't need to take it out. As long as you've gotten it checked and it's confirmed that it's fibroadenoma, you don't need to take it out.
Okay.
If you are more than 25 and it's a fibroadenoma, then we need to biopsy it.
Okay. Is it expensive to go through the surgery?
So it depends on where you do it.
Yeah.
If you are in government hospital, you talk about NHIS and all of that will cover some of the costs of the procedure and the things you go through.
Okay.
So it may not be that expensive in that regard. But if you are not, private sector is expensive.
Okay.
I mean, treatment of cancer general is an expensive venture. Okay. And so that's why you want to do something that you don't need to do so much when you have the problem.
Okay.
So when you screen, then you treat it quicker. It's very cheap to do that. If you get certain types, like we call something HER2 receptor enriched type of breast cancer, that one that you need a certain specific medication called the biologics. And those ones are expensive. But even that, recently I've heard that I think Ghana Health Service or NHS or something is key and they are adding it to the list of medications that you can have. But otherwise, hitherto that, it was a very expensive medication. Okay. So generally, cancer treatment is expensive. If you let it become complicated,
it's more expensive.
It's more expensive. So you might as well just try to figure it out early enough.
Yeah. And we're gonna, bring this conversation to the end. But I'm gonna divert the conversation a little bit. You've been to other countries, you've traveled across the world, and where do you see the Ghana health industry right now?
Okay.
You've seen better and then you've seen worse.
Yes. So there's something I always say that if you aim on the sky, you fall on a tree. Yeah. If you aim on a tree, you fall on the ground. If you want to aim on the ground, then get a shovel and start digging. So because most of the time, when they say the sky is the limit, literally speaking, it means that you're not going to get there. But it helps you to push harder and faster. My problem has been the fact that we always look at people that we are better than. For example, countries like Sierra Leone, Gambia, Liberia, I mean, for them, Ghana is like a first world when it comes to health. Yes.
Really?
Yes. Infrastructure is a problem. And so if you take Sierra Leone, for example, I've had clients from there. And like when they come to Ghana, it's like, Charlie, they have arrived. I've had clients from Liberia, the same thing. There are people that...
So we know that bad.
So that's the point I made earlier. I don't want to feel that because aiming
we
on
are
the
looking
sky,
at people that we are better than.
Exactly. Let's compare ourselves to Kenya. Kenya is better. Tanzania is better. I'm not going to say South Africa because now when you say South Africa, people say, South Africa is a different thing. But Kenya, Tanzania, I mean, they are better than us. There are a lot of things that we have to do. And as Ghanaians, we are not deliberate in the things we do. We do things absent-minded and we don't set things to achieve. And so if you look at it in the spectrum and we say that we are doing better because we are looking at Sierra Leone and Gambia and everything, then it doesn't make sense. I mean, how many of our government hospitals are able to do even MRI scan? Those are the things that are important. If you take South Africa, one province, Western Cape, that whole province is the size of England. You understand? And you can check. It has only 2 teaching hospitals. Grooteskies Hospital, which serves the University of Cape Town, and then Tygerberg Hospital, which serves Stellenbosch University. 2 teaching hospitals, but the things they do in between the 2, the size of England is the area they cover. If you take Accra, you can say we have 4 teaching hospitals within a radius of about 25 kilometers.
Wow.
UGMC, 87, It's called regional hospital, but I think it's at the level of a teaching hospital, if you ask me.
Okay.
And then Kolebu. It's nowhere compared to what those two hospitals
combine these hospitals together. It's nowhere compared.
Exactly. Because we don't do deliberate things. How are we setting criteria? How are we working with protocols? How are we making sure that even the training that we are given, we are subspecialized
policies.
Spaces. What are we putting in place to make sure that the type of care, quality control, quality assurance, what are we doing? We are not deliberate. When something happens, fanfare, media, noise, then it dies away. And those are the things. We are very intelligent people. Like, I was in Columbia University as far back as 2010. The one who was the geneticist for New York Presbyterian Hospital is a Ghanaian. The one who was doing a specialty called phytomaternal medicine, she's called Cynthia Jemfi. She's a Ghanaian. You get it? Like, these are Columbia University top places.
Yeah, if you go to everywhere across the world, you like top places, Ghana, you see Ghanaians there.
So when you think about it, it's more of we being deliberate and having a policy guide how we want to develop and how we want to expand. We can easily become the health hub for the West African sub-region, not even Nigeria. We can easily become. And the people who will come in, the foreign exchange that will come in, it will become like a health tourism. And these are things that we haven't deliberately looked at. And because we haven't looked at that, we are not even motivated to develop our systems in a way that it can be done that way. And that is the problem. If you have stroke and the blood in your head is clot, or there's a clot thing they want to remove, it's only a private place that we can do in Accra. Those are the things.
Problems of how do you think we can solve these things?
So first off, I mean, we have to be deliberate about it. We must decide what we want to achieve. Decision we make should be based on procurement and how much people are going to make from the procurement. So we can decide that, okay, what is our objective for Ridge Hospital? What's our objective for Kolebu? Objective for UGMC, 37. 37 is a national disaster center. You understand? It's an idea. How have we put things in place to make it like that?
Yeah.
Ridge Hospital can become like a cancer center. You know, when we start by deciding this is what we want to achieve, we start by there. Then we go into the human resources. How are we developing people? Look at the number of people that recently came out, Guest Fund has funded. Everybody's doing MPH. You understand? How is that transforming the health sector? People are doing MPH. How is that affecting policy? Because these things are not health management, hospital management, public health thing. How is that transforming us? You understand? People take scholarships, go and do all kinds of good stuff. Get Fund and hospitals could decide that let's agree that every year you're going to train 10 specialists, doctors, 10 specialists, nurses, 10 specialists in other fields every year. Within a period of 5 years, each of these hospitals are going to get 50 of each. Do you think that will not change?
Of course.
The idea?
Make a lot of impact.
The more, as we were speaking earlier, when you go outside and you get certain training and you come back, your perspective change.
Yeah.
And when focus you can't be in the same thing and have a different perspective. And until you do that, China, Japan, South Korea, they all have done that. They send people outside, go and learn technology, go and do this, come back. What has happened to China now? South Korea.
Boom.
If they were to stay in China and say they are learning IT, they have been where they are. No. So we have to decide that this is what we want to do. This is a drive. Let's groom people in this phase. In South Africa, before I'll bring out intestine on somebody's skin, because maybe the bomb is a problem. So I want feces to come from here. We call that stoma. The person who comes to draw where I must put is a nurse. We call them stoma sister or stoma nurse. Where she puts it, me, the doctor, that's where I'll put it. I can't put it anywhere else. Why? Because she's trained.
Yeah.
That's her field.
Yeah.
When you're talking about mental health and everything, when somebody is trained, they get the respect.
Yeah, definitely.
And they're able to do what they have to do.
Yeah. But just so we know, all these people, like if they were to go to outside Ghana and learn, acquire knowledge, they're not coming back. Look at the nurses recently. Look how many people travel. They're not coming back because of the system. The system is hard.
The thing again, I can give you reason why policies affect things that we do. In about 20 years ago, or before that, we didn't have a college that trained specialists in terms of doctors in Ghana. There was a government policy to set up a training center, Ghana College.
All right.
I think it's 2003, if I'm correct. So Ghana College was set up. Immediately that happened, it started retaining doctors who hitherto would have traveled outside the country. They stayed, they specialized, they were funded for the training. And most of them are still around. Now, it has changed again to the old setting. You understand? So the point is that if we were to put down the right policies, why are the nurses going? Salary?
Yeah.
They call something role extension. Role extension. Where, as a professional, you should be able to extend the role that you play to make life better for yourself and even the patient.
Yeah.
How are we role extending our health workers? So when you wake up and you
practice what you preach, basically.
Yes, you come mundane. You come give injections, do this. There's nothing there. Two things. Look, personally, when I work in any environment, there are two things I look at: job satisfaction and salary. Quarter, you must get one of them. Do you understand? Quarter, you must get. But if you're not getting any, you can't compare how much you make in UK to Ghana.
Nah.
You understand? We can't expect that you'll be paid the same salary in the US in Ghana.
Yeah.
But we can create the environment where people can work and be satisfied. That when they even go home and the supposed even meager salary come, in their heart, they know that they are saving lives. They are helping people. Look at what happened in Central Region recently. Patient not well, this and this, going to get down by the roadside. And then, that. You see, I know people will abuse the health workers and everything, but I don't think that any rational human being will go and put a sick patient by the roadside and say they should die there. Why did they behave like that? You understand? Because if you understand, Shakespeare said that for every madness there's a...
But is there a reason though? What could be the actual reason for you to leave someone there? So,
I mean, I wouldn't know, but I'm just using as an example that again, in situations like that, we need to interrogate. I can on top of my head.
So you mean something triggers somewhere, something might have happened wrongly somewhere?
The point to which a human being, for a human being, let's assume without admitting that what happened, they went to dump the person there. For a human being to get to the point where they can leave another human being who is sick to lie down there and die. You understand? There should be something off.
Yeah.
Either the person has switched off, and then why?
Yeah.
You understand?
Or maybe we're not getting the information right. Yeah.
Why? The person is trying to shirk responsibility. Why? It is not as simple as we make things.
Yeah.
And I'm not holding brief for anyone. But the point I'm making is that if we put things in perspective, where we are deliberate about solving problems, our health sector in Ghana would become a hub in at least the West African average. And it goes by being deliberate about planning and policy, human resource development and expansion, and facility. Yeah. Just these three things should be able to help to even retain people. Because I can tell you for a fact, I've had conversations with people. Some of the people who leave is because of job satisfaction. It's because they can't see where they are moving into in role extension. General nursing, what do? You sit there, you become SNO.
They don't see
PNO,
future in what they are
matron.
doing. Yeah.
What excites you? And as human beings, you all get excited by things. What excites you? What do you want to do with your life in the profession?
Yeah.
That is relevant. We don't do that.
That's what keeps you there.
That is what keeps you there. So even if the salary gets you by, you're okay. Because at the end of the day, you know that what you are doing is impactful. Every human being wants to make an impact. We can pretend all we want.
Yeah.
And if you go through the Maslow's theory of needs, as you get higher, it gets to the point where you want to have influence.
Yeah. Definitely.
Every human being.
Yeah.
When you've stayed, you have a house, you have a place to sleep,
you
are comfortable. The next thing are these things. And so somebody who is working, gets salary that is reasonable, is not starving, that's the next person is looking for. If the person is not finding that, they'll look for it elsewhere.
Yeah. Anyway, thank you so much. I mean, thanks for coming. My last question will be, be in the 2024 election year. As a frontline worker, what advice do you have for the youth?
Well, I mean,
I say we should be peaceful.
We all have to just go and vote. If you want to check the count, which is one of the things, the beauty about Ghanaian democracy, is that the ballot papers are counted. Everybody's helping count it. You understand? So you vote, you go home. When polls close, you can come and stand there and count. There's no point in voting, lingering around, lurking in corners, trying to stir up trouble. Because in the end, somebody will be chosen anyway. Whether it's your party, not your party, somebody will be chosen. Yeah. And we all have to marshal and move on. You understand? So there's no point in losing your life at the end of that. Or getting maimed. Or, being in prison because you are the one who is the assailant in a problem. There's really no point. And so for me, that's the long and short of it. We should all vote. We should all decide who we want to vote for. We should finish voting, go home. If you want to go and check the counting, go and count. Afterwards, that's the end of the story. Yeah.
Just be peaceful.
Yes.
Just be peaceful. Thank you so much for coming. And if people want to find you, how can they find you?
I have
your socials, your number.
I have social. I have Instagram account. It's called Paulo Ross.
Okay.
Or P Rossi. I have a consult that I run called P Rossi Consult.
Okay.
I do second opinion, medical legal things.
All right.
I've done a few in the UK.
Oh, you do second opinion?
Yes.
Oh, really?
Recently, some banter with NHS that I was involved in. In South Africa, I also help to find the right medical care for people. So if let's say like now I'm actually helping about 4 people as I speak to get some specific health care that we don't provide in Ghana. If you provide in Ghana, I'll make sure that you get it done here. If not, we'll find a way to get the right thing done. I also give a lot of health education. So like as we're doing now, if anybody has any platform that they want us to keep health education going, that will be something that I do. So my Instagram page, which is the professional one, is the P Rossi Consult, that you can find me there. Otherwise, my business WhatsApp number is also 0279 134 333. That's what I use for my business. The other one that we chat on is
a personal one. All right. One. That's fine then.
Basically, that's where you can find me.
Yeah.
I work in 37.
Okay.
So if you miss all of this and then you want to come and find me, I'm in 37 Military Hospital.
Yeah.
And if you come and look for Dr. Edu Jemfi or Lieutenant Colonel Edu Jemfi, you will also be able to find me.
Okay. And all the information is going to be on the screen as well, as you can see. And thank you so much for watching us. Thanks for your time. If you've watched up to today, till now, then that means you are blessed, and thank you for supporting us. And please share the link to everyone that you know to support this journey. Thank you so much for watching us. See you soon.